الخير واهلا بيكم في المؤتمر ال 19 المفروض يبقى ال 21. يا رب دايما نشوفكم كده بخير. وطبعا بشكر الاستاذه الدكتوره منى على مجهودها مع المجموعه المنظمه اللي عملوا مجهود رائع لانجاح المؤتمر كما عهدناه كل سنه، ونوعدكم ان كل سنه ان شاء الله يبقى فيه ما هو افضل وما هو جديد. Dear colleagues, dear audiences, dear chairman, I would like to talk in a couple of minutes about positioning of therapy in patients with IBD. My agenda will include the pathogenesis and the growing armamentarium of drugs in the field of IBD, and I will talk about the factors we rely upon when we position therapy, which is the 5 pillars: efficacy, safety, patients-related issues, cost, and the level of evidence, and I'll end up by a very short take-home message. By the year 2023, you can see we have learned a lot about the pathogenesis and the pathophysiology of IBD, the cells involved, the cytokines, inflammatory products, inflammatory pathways, and more recently, we have learned about the brain-gut axis, the role of the leaky gut, the role of bile salts, microbiota, and the role of fibroblasts in fibrosing types of IBD. So this resulted in having a bigger armamentarium and a larger group of drugs and therapies, which we should rely upon in positioning and choosing which of which will be the best for our patient. And you can see the group of anti-adhesive drugs, sphingosine phosphate modulators, anti-interleukin specifically to the subunit P19, JAK inhibitors, other small molecules, and on top of the list on the left side, you see oral anti-TNF, which is really something which should be smart enough, since the same way as an anti-diabetic semaglutide has proved to be effective in diabetic patients, we look forward that oral anti-TNF may have a definite good role in treating of our patients. So no worry that by the year 2026, we will find newer groups, including risankizumab, brazikumab, as well as the same year to 2022 was the year of small molecules, where we have approval of a big number of small molecules such as ozanimod and filgo and upa. Here by the year 2026, more and more therapies will be available. And you can see this big list on the right and left side used in treatment of Crohn's and in ulcerative colitis. And the future carries in the pipeline more and more. So really, it's our task to learn how to modify our skills in order to properly position and choose our therapies. Because it's not always clear-cut. Sometimes when you put everything together, the complication, the extent of the disease, the inflammatory burden, whether the patient has a perianal disease or not, extraintestinal manifestations or not, sometimes you get a straightforward case of a male patient, 32 years, with a fistulizing perianal disease. In such a patient, no way that anti-TNF is the best choice. And in a female patient with Crohn's disease and extraintestinal manifestations, which happens to be, for example, psoriasis, in this patient, ustekinumab will definitely be a very good choice in this patient. Not always crystal clear. In a middle-aged patient who has pancolitis with a Mayo score 8 and a subscore 3 without any extraintestinal manifestations, here you have to balance which of which would be the best for your patient. Because gut-selective agents are good in such a patient, but you have other many choices. Anti-TNF could work, anti-interleukin 23, and small molecules could also be effective. So we have to learn out how to position therapy. And again, I emphasize the importance of relying upon the 5 pillars, which is efficacy, safety, some patients-related issues, cost, and at the end, maybe the level of evidence will be the only thing we may rely upon in positioning the patient therapy. Starting by efficacy, you will find that most of these systemic reviews and network meta-analysis will show that comparing any of the drugs we use, any of the small molecules, any of the biologicals, comparing them with a placebo, whether we are talking about clinical remission or endoscopic healing, you will find no significant difference. Whether you're, again, emphasizing, whether you're talking about clinical remission or mucosal healing, Comparing it with a placebo, there is no significant difference. And here comes an important study, which is the Aurora study, showing that in most of biological therapy used, after 1 year, you will find that most of them appear equally effective after 1 year. Although we have this feeling that most of the biologics and small molecules work similarly, but some of the studies, like this study by Burley, showing that whether in Crohn's disease or in ulcerative colitis, there is some difference. For example, anti-TNF may have an upper hand in induction, while if you compare it with VDO in maintenance, you will find some equality in maintenance or no difference, in spite of the fact that in induction they were somewhat different. Again, not everything is consistent. Real life studies show different results. In this real life study, including 722 patients in ulcerative colitis, some of them were naive, other of them were non-naive exposed to anti-TNF. In such patients, whether we're talking about clinical remission or deep remission, you could find VDO superior to anti-TNF in a real-life study. When we go to a meta-analysis, you find different results. In naive patients, you find infliximab number 1, VDO number 2, ustekinumab number 3, and in patients who are exposed, you find tofa number 1, ustekinumab number 2, and VDO number 3. I am talking about patients with ulcerative colitis. And you can see how results are different. Real-life studies show different results from meta-analysis. And again comes an important study, which included 2,637 patients on VDO compared to other biologics, showing here that using gut-selective therapies, in spite of the fact that they are very safe and they are very selective, but they add to the risk of developing extraintestinal manifestations. So, things are not easy. To make it more complicated, newer drugs, such etrasimumab, which is a gut-selective, working by two mechanisms, anti-leukocyte retention and anti-leukocyte trafficking. Comparing it with infliximab, you will find no difference at the week 54, whether we are talking about clinical remission or whether we are talking about endoscopic improvement or endoscopic remission. So not everything new is always better. Shifting gears to Crohn's disease, you will find from this study, which included a lot of database from the midline in Bayes and Cochrane, that adalimumab or infliximab plus an immune modulator is superior in induction and maintenance in patients with Crohn's disease. And even when you try to compare the efficacy of both of the most commonly used anti-TNF, adalimumab and infliximab, you will find no significant difference in naive or in non-naive patients when you target steroid-free remission or clinical response. And in the CView study, which was a head-to-head study comparing adalimumab to ustekinumab, there was no difference in naive patients. Going to non-naive patients, you can find here that patients who failed anti-TNF, ustekinumab in patients with Crohn showed some significant difference when compared to VDO. So I feel that when we rely upon the efficacy, maybe some of you will feel confused because meta-analysis does not go exactly with real-life study results. And not every new drug showed or proved to be better. And if we use a gut-selective therapy, then you may have the risk of inducing an extraintestinal manifestations. So things are a little bit confusing. So what should we do? We are looking deeper into head-to-head studies, and unfortunately, we have minimum of these, such as Varsity, Efficacy, CView study, Hibiscus, Giardenia. Some of these studies are already available results, but many of the others are still. But at least you can get an image what to use. In Crohn's disease, for example, head-to-head studies proves that in naive patients, infliximab is equal to adalimumab and equal to VDO, while in experienced patients, ustekinumab proved to be superior. When you go to ulcerative colitis in naive patients, infliximab, adalimumab, and golimumab, there was no difference between both. But VDO was found to be superior to anti-TNF. Now shifting to experienced patients or non-naive patients, VDO versus another anti-TNF result were really so controversial. So let's handle another issue. It's not only efficacy to rely upon. Patient issues. What does the patient prefer? What does the patient look to? Patients usually look to safety, and they also look to efficacy, but they respect so much the route. If you ask the patient, you will take an oral therapy, definitely he will prefer. If you will need a parenteral therapy, and try to ask your patient, which of which would you prefer? Would you prefer a subcutaneous to a parenteral? Definitely he will choose the subcutaneous. So please respect the patient's needs. And if we go more deeper into the molecular level, which we don't have the luxury really to do this, but if you can study oncostatin expression, for example, oncostatin expression was associated with a higher risk of failure of anti-TNF. And if you can study the microbiome, which is the interest of Professor Mona Higazi, of course, if you can study the pattern, then you can find out some patterns which show better response to anti-TNF and other microbiome patterns showing a lower or least response. Because we have seen Schreiber from the ECHO Congress 2022, putting this reality, if we don't go towards personalization, we will still always have difficulty to position our therapy. And the end result is if you understand properly which inflammatory pathway is the firing one, and if you study this mechanism properly in the patient through a blood sample and a urine sample, and then you integrate this with the mechanism of action, you can end up stratifying your patients into groups and selecting the best therapy for each particular patient. Shifting now to safety, which is the third pillar we rely upon when we position our therapy. Of course, the most important issue of safety comes when you use anti-TNF with immune modulators and the risk of lymphoma, which of course happens to occur in an adjusted hazard ratio of 5 when you combine both. So for this reason, please use azathioprine cautiously, because we don't have the luxury to test for TPMT before we start treatment. So please monitor the patients and avoid it for a long time, and avoid it in elderly patients to avoid the risk of lymphoma, which is really should be considered if you need to use it for a long time. Fortunately and luckily enough, that most of the drugs we use, whether biologicals or small molecule, again, when they are compared with the placebo, in most of the systemic reviews and network meta-analysis, you will find that most of them have a similar safety profile when compared with the placebo. Some of the meta-analyses have shown a superiority of VDU in patients with ulcerative colitis. Other studies have shown this was a real-life study, which included the same number, 722. It was the same one I mentioned before. And in this study, you can see that in patients treated with anti-TNF and VDU, there was no difference at all, whether in naive patients or in patients who were exposed. In patients with Crohn's disease, ustekinumab proved to have the lowest risk of serious events and serious adverse event and serious infections, followed by infliximab. And when you compare adalimumab with ustekinumab, you will find high safety profile in both drugs, except maybe in the injection site, which is somewhat more painful on the side of adalimumab, lesser painful in the side of ustekinumab. And the end of the day is that you cannot rely upon efficacy and safety alone. Let's look to an important aspect, which is the cost. Studies have shown, this European meta-analysis have shown that the annual cost of patients having inflammatory bowel disease comes from the use of biologics. It's not from hospitalization. It's not from investigations or surgery. It is, which is in the blue color, it's from the cost of the biologic. Another meta-analysis from Europe also have shown that the most important factor which makes the patient non-reliant on his treatment, non-adherent to his treatment, is the co-payment he has to pay. So please, we have to respect the cost, and maybe biosimilars added a lot in this aspect. They are supposed to be more cheap, and the good news is that many others, other than anti-TNF, such as ustekinumab, there are trials to produce biosimilars to have the advantage of the lower cost. Sometimes at the end of the day, we are kept with the level of evidence. So how I am going to choose the best drug for my patient? If I don't have a lot of data of the patients, for example, you have a patient with perianal disease, and you have a lot of studies telling you that anti-TNF is better than Vido and ustekinumab, although Vido and ustekinumab works, but in such a case, you have to choose the anti-TNF. In a patient who has Crohn's disease and is going to undergo surgery, then what are you going to give this patient? Anti-TNF with azathioprine proved to have effective and have a lot of data, more than Vido and ustekinumab, which also proved to be effective. But we should use the medication which has the better and the highest level of evidence. In pouchitis, antibiotics are better than biologicals. Level of evidence is more that antibiotics are better than probiotics. So here we have to respect the data. In acute severe, we have recently learned that small molecules have a rapid onset of action. We can use them definitely in treatment of our patient. But we still, to this moment, have more data that infliximab and cyclosporine, if available, would be the most or the best choice for our patients, in spite of the easy and fast mode of tocilizumab, which is oral. By the end of the year 2023, we have this algorithm, which is published in Nature Review, Gastroenterology and Hepatology, and it tells you that you have to use everything in order to choose your patient's, the position of therapy in your patient. Rely upon the patient's need, number one. What does he prefer? Number two, look at the comorbidities, infection and malignancy. If your patient has infection or malignancy or a comorbidity, use the more safest drug, which are the ustekinumab and Vido. And if you have a high inflammatory burden or a fistulizing disease or a disease which affected the quality of life of the patient, please go towards anti-TNF and other medications such as ustekinumab. And remember that ozanimod, a small molecule, and this modulator has proved to be very effective to the degree that it was listed in the first line of therapy in patients having a high inflammatory burden. What I mean is everything is changing fast, so we have to follow, update, and choose the best for our patient. And please don't forget that my final take-home message will be there are 5 pillars to use: efficacy, safety, patient issues, cost, and level of evidence until we reach this moment which we can personalize our therapy. By understanding mechanisms of therapy with the mechanism of drug acting, integrating both, reaching what we mean by personalization. And in spite of all of this and the hard work we do in positioning, we still may fail. Whether primary failure or secondary failure is a heavy task and a heavy duty because it occurs in 50% of our patients. And here comes the role of the greatest Professor Amr to tell us how are we going to reach cure and how are we going to solve the problem when we do everything to position and then we come to the point we say we have failed. And we need Professor Amr to tell us what to do. Thank you, and any questions?